Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Today, our topic is an integrative approach to hypertension with Dr. Mark Houston. From today's discussion, I hope to gain a better understanding of what causes hypertension, why it's so important to treat it properly, how to test for it, and the pluses and minuses of the various treatment options with a focus on diet, lifestyle, and nutritional supplements. Hypertension means that you have high blood pressure. And as Dr. Houston points out in his latest book, this does not mean that you are overly tense. High blood pressure means that your blood pressure is more than 120/80. According to the CDC, in 2021, hypertension was a primary or contributing cause to 691,000 deaths in the U.S., and nearly half of adults are defined as having hypertension, 48.1%. And apparently in 2021, they're defining hypertension as blood pressure greater than 130/80, or taking medication for hypertension. Dr. Mark Houston's the director of the Hypertension Institute in Nashville, Tennessee, and he's the go-to expert on cardiovascular disease in the functional medicine world. Dr. Houston is triple board certified in hypertension and as an American Society of Hypertension Specialist and fellow of the American Society of Hypertension, internal medicine, and anti-aging medicine. He also has a master's degree in human nutrition, as well as a master's of science degree in functional and metabolic medicine. Dr. Houston teaches doctors around the world about cardiovascular medicine as part of the A4M program. Dr. Houston is also a very prolific author, having written many papers and books, the latest two being Precision and Personalized Integrative Cardiovascular Medicine and Controlling High Blood Pressure through Nutrition, Nutritional Supplements, Lifestyle, and Drugs. Dr. Houston, thank you so much for joining us.
Thank you, Ben, and thank you for the kind introduction. It's good to be with you again.
Yeah, by the way, this book is great. It's really incredible. It's got everything a clinician would want to understand hypertension better. So help us understand.
That was 1 year out of my life writing that.
I bet it was. I thank you for that. So tell us, what is hypertension and what causes it?
Hypertension has really not been well defined in the past by most of the hypertension world. So the book was designed to allow people to understand what really causes high blood pressure. You know, everybody thinks, oh, it's my genes. That's what causes high blood pressure. Well, yeah, there's clearly genetic reasons for high blood pressure, but there's a lot of environmental influences that contribute to those genetic expressions of high blood pressure. So basically, if you break down into three simple things, three finite vascular responses cause high blood pressure: inflammation of the arteries, oxidative stress in the arteries, and immune dysfunction in the arteries. And those lead to endothelial dysfunction, glycocalyx dysfunction, vascular and cardiac smooth muscle dysfunction. The arteries become very stiff, non-elastic, and therefore the amount of flow going through an artery is going to increase the pressure by simple physical principles of stiffness with increased blood flow. So that's the basic physiology of hypertension. And then if you start looking at genetics, and we measure all that in the Hypertension Institute, we can determine what gene may be causing the hypertension and how to treat it with either a drug or nutrition or supplement.
Okay, well, let's make sure we get into that in a few minutes. So, currently, hypertension is blood pressure higher than 120 over 80. Is 120 over 80 ideal? For example, is 110 over 70 better?
There are several large cohort studies that have said the risk actually starts at 110 over 70.
Oh, okay.
But no committee is going to recommend that because no one can achieve 120 over 80. So they're not going to say just go to 110 over 70. But you're pretty good at at 120 over 80. That the risk doesn't increase dramatically. But the thing I think everyone needs to know is there's an incremental increase in risk for every 1 millimeter of systolic and diastolic. So if you're 121 over 81, your increased risk over the 120 over 80, and it goes up proportional to that. So to set like some arbitrary level, okay, let's say it's 130 over 90, kind of misses the whole point of, well, there's a people between 120 over 80 and 130 over 90 who have incremental increase in risk.
And that was kind of the rule for a number of years was, yeah, it's okay if it's up to 130 over 90. You don't really need to treat it until then, right?
Yeah, it turns out that is not the case.
Right. Now, a lot of patients have elevated blood pressure and let it go because they don't feel bad and they don't really want to take medication. And I think they don't realize how dangerous it is. So why is elevated blood pressure so damaging?
Well, it's going to damage every organ that requires a blood vessel going to it, which is everything in your body.
Right.
The big ones are ischemic stroke, myocardial infarction, congestive heart failure, kidney disease, aortic aneurysms. And that's usually the organ damage that is manifest under the cardiovascular consequences of hypertension.
Now, what's the proper way to measure blood pressure? My experience is you go to the doctor, maybe you're standing in the hallway or you're sitting, your arms down. They measure your blood pressure once in one arm. But that's ideally not the best way to do it, correct?
No. 99% of the time you go into a office, the nurse and or the doctor don't do blood pressure measurements correctly. I've seen it. I know it happens. So let me tell you how you should do it. You tell your patients when they're coming in for their visit not to smoke, not to drink coffee, and not to drink alcohol. Or take any other things that could raise their blood pressure. They come in, hopefully having a good night's sleep as well, and they have to sit in a chair with the feet on the ground and their back supported. And they rest for 5 minutes, and then you check their pressure with a cuff that, with their arm extended right at the level of the heart and supported. You do both arms and you do the leg pressures. You do a sitting, standing, and lying blood pressure and a leg pressure on the first visit. That's routine. After that,
I don't think I've ever been to a doctor or hospital anywhere.
You won't get that unless you go to a hypertension specialist, probably. But on the subsequent visits, assuming all those were okay, you can do just one arm blood pressure in the proper position with the arm extended. And you got to teach people how to do it if they do home blood pressures, because most people don't do it right.
And then ultimately a 24-hour blood pressure is probably the most beneficial, right? Most significant.
Yeah. Once you identified an office reading that's high, you confirm that with a 24-hour ABM, because you not only get the average pressure, but you also get other things that are important, like what's the dipping pattern, what's the nocturnal blood pressure, are there morning surges? So all these things factor into risk, but also when and what medicines to treat them with.
Do you have what's the ideal way to do the 24-hour blood pressure? Do you have a specific product that you like to use?
We have several that we've used. The one we've used mostly is either Space Labs or Hewlett Packard.
Okay. Now, I read in your book, I was surprised to read about white coat hypertension. So what that means is you go to the doctor's office, your blood pressure is elevated. You go home, it's not. And I think the thought is among most people is, well, that's no big deal. I was just stressed out, so I don't have to worry about it. But they really do need to worry about it, correct?
That is correct. Used to, we just blew off white coat hypertension as nothing but stress in the doctor's office. Turns out clinical studies, and there's many of them now, having done thousands of patients, show that white coat hypertension has a risk that is in between being totally normal and having sustained high blood pressure. So you are at risk, and you probably need to be treated for white coat hypertension, because if you do that in the office and you get stressed out coming in there, you're probably increasing your pressure all day every time you get under stress.
Right. So let's get into, well, you mentioned genetic factors. So you like to do genetic testing. How does the genetic testing help you to manage patients?
We developed a gene test with Vibrant Labs in San Francisco that has 25 SNPs, including high blood pressure genes, dyslipidemia, coronary heart disease, and diabetes genes. And what has really helped us is when we get those hypertension genes back, you know exactly what's driving the high blood pressure genetically, and specifically what drugs you can use, and you don't have to guess. So rather than saying, well, let's just try this drug or try that drug, you know exactly which drug is going to work the best.
One thing you mentioned in your book was stratifying hypertension into these two different types. And you do this by measuring plasma, renin, and aldosterone. And I never heard of a doctor doing that. It sounds like that's something that could be really beneficial, but I don't think that's being done by hardly anybody today.
You're probably right. We're one of the few institutes that has actually does it, but also we've studied how much help it is in selecting therapy. So it's easy to do. You have the patients come in. They don't have to, reduce their salt intake or drink a lot of fluid. It's just random. You get a plasma renin activity, it's called a PRA, and a simultaneous serum aldosterone level. And they can't be on medication, obviously, when they do this, because that messes up the numbers. And then whatever those numbers are tells you the type of hypertension that they have physiologically, not genetically, but physiologically. And it tells you what drug classes are most important. So the two classes are high renin and low renin. So the plasma renin activity over 0.65 is high renin hypertension. If it's below 0.65, it's low renin hypertension. Now, the reason you do an aldosterone level with it is sometimes the PRA will come back right on the borderline and you can't really tell which one it is. And then you do a ratio called the aldo-renin ratio, ARR. And that ratio will nail it like 99% of the time. And you know exactly what to do. So if it's, for example, high renin hypertension, your best drugs are ACE inhibitors, ARBs, and direct renin inhibitors. But if it's low renin hypertension, it's a diuretic and a CCB, or calcium channel blocker.
Okay, cool. Let's get into diet and lifestyle. What are some of the most important lifestyle factors that can help to lower hypertension?
There's three that are the most important, well, actually four. Low sodium, below 1.5 grams per day. High potassium, at least 5 grams per day. High magnesium, like 1,000 milligrams a day. And at least 12 servings of fruits and vegetables per day. If you do those right there, that will drop your blood pressure typically about 12 to 15 on the top and 6 to 8 on the bottom.
Now, the sodium thing is controversial. It's gone back and forth in terms of how important it is. A lot of doctors say, well, only a small percentage or only a percentage of patients are sodium sensitive. How many patients do you think respond to reducing sodium?
So what you just said, that these doctors are saying that sodium is not important if you're, quote, salt sensitive, is another major myth that we need to presently dispel
Okay.
forever in the minds of your listeners. Sodium is toxic in any form.
Okay.
Once you get over 1.5 grams per day, it's not all about blood pressure. Your blood pressure may or may not be salt sensitive, but it gets into your arteries and it makes them stiff. And when you get that, then it leads to stroke, heart attack, heart failure, and kidney failure, proteinuria in the kidney. All those are related to sodium intake. It also reduces nitric oxide levels, which makes your vessels even stiffer. So sodium is important. It is toxic. And the more you eat, the worse you will be, whether your blood pressure goes up or not. Now, you balance the sodium problems with potassium and magnesium.
Right. And what type of dietary approach is best for controlling hypertension?
So in my book that you just showed there, we use what's called the HIP diet, HIP. It was a kind of a cute name for Hypertension Institute program.
Right.
And what it is, it's a modified DASH2 diet with a little Mediterranean flavor thrown in, with the qualifications of sodium, potassium, magnesium, the fruits and vegetables, high quality protein, and getting rid of refined carbohydrates. And if you do that and follow the HIP program, we've got recipes in the book, 2 chapters on nutrition. You can pretty well get that program going easily.
What role do toxins play in hypertension?
Huge. Toxins drive not just hypertension, but also coronary heart disease and heart attack. So you got to measure the big ones, arsenic, lead, mercury, and then pesticides and organocides. And if those are elevated, you do your best to get rid of them.
Okay. What about micronutrients?
So micronutrient deficiencies can drive hypertension and coronary heart disease, arterial stiffness, all kinds of problems, including endothelial and glycocalyx dysfunction. We use micronutrient testing from Vibrant Labs out of San Francisco, which is the same company that we do the genetic testing. I like it because it measures both intracellular and extracellular micronutrients.
Right. Correct. Yeah, I love that test. What about the importance of exercise?
Very important. You need to do a combined aerobic and resistance training program for 1 hour a day, 6 days a week. When you do that program, the exercise reduces inflammation, it improves arterial elasticity, it raises nitric oxide, reduces stroke and heart attack risk. And typically, once you're trained, the blood pressure will drop about 12/6 once you're in good condition.
Now, a lot of the way to understand blood pressure has to do with the arterial walls and the lining of the arteries, the endothelium. How do we address that? And maybe you can talk about the importance of the endothelial lining and the glycocalyx of the arteries.
Right. So endothelial dysfunction and glycocalyx dysfunction occur decades before you get hypertension. I'm talking sometimes 2 or 3 decades. So being able to identify those with non-invasive vascular testing is very important. So the glycocalyx is outside the endothelium. So it's the one that hits first. Once it's damaged, then the endothelium gets damaged. And once it's damaged, then the vascular smooth muscle wall gets damaged. So think of it this way. The first thing that happens is functional changes in the endothelium, the glycocalyx, that reduce nitric oxide and cause the 3 finite responses of inflammation, oxidative stress, and vascular immune dysfunction. And then those feed into stiffness of the arteries. Now you've got structural changes. The artery wall not only is stiff, but it starts to get thickened and the lumen gets narrowed. And then you have what's called a narrow medial lumen ratio. And what's happening there, in essence, is the artery is trying to protect the organ from damage by constricting to reduce that pressure that's going into the organ. But when that happens, the long-term effect is you reduce blood flow and oxygen through the artery to the organ, and now you get ischemia. Well, if it's a brain, it's a stroke. If it's your heart, it's angina or heart attack. So what you want to do is back up and start treating everything at the beginning so you don't get to those bad things later. So for the glycocalyx, you use a glycocalyx promoter. And there's only one out there that I think is really powerful and proven in clinical trials, and that's arterial, which is made by Calorie Labs.
What about I think the guy who developed that for Calorie went on his own now and developed a newer product. You know about that one?
I have looked at all the products that are glycocalyx promoters, okay?
Okay.
And I've looked at the science, and I will tell you that I don't know the political history about who did what with where. I just know that the arterial by Calorie is superior to any other on the market by a landslide. So that's the only one I'd recommend. It's 2 capsules a day, one in the morning, one at night. Then you add to that a nitric oxide promoter. And once again, Calorie has the best one on the market. It's called Vascular. It's 5 times more potent than any other nitric oxide on the market.
Now, you used to recommend the Neo 40, correct?
Yeah, Neo 40 was a great product, but probably it's very short-lived. It only lasts about 6 hours, whereas Vascular lasts for 24 hours, and it stays above the magical threshold for arterial elasticity, which is around 200.
What does it have in it that allows it to do that?
The Vascular?
Yeah.
It has a lot of things in it that are nitrite-like, but it also has hydrogen sulfide, which is a PDE5 inhibitor. So you get kind of a bidirectional hit that really jacks up the nitric oxide levels.
Interesting.
So if you use those two together, you can really improve glycocalyx endothelial function. And then, interestingly, both of them together also improve the arterial function, the actual artery wall, and the elasticity over time gets better, relaxes, and now the pressure actually starts to fall with those two products independent of a medication.
Are there any lab tests that indicate that early endothelial glycocalyx dysfunction?
Yeah, there's a couple. If you want to do blood tests, it's asymmetric dimethylarginine, ADMA.
Okay.
You get that from Cleveland Heart, which is part of Quest. You can also do the strips, the go into your tongue.
Okay.
Strips are really good to see if your levels are high. And then, of course, we have 2 machines that measure endothelial dysfunction. One of them's called EndoPAT, and the other one's called computerized arterial pulse wave analysis. Both of those will measure endothelial dysfunction. And the pulse wave analysis gives you that and arterial stiffness in one test.
Cool. What about any of the other lab tests like myeloperoxidase or any of the other tests that are trying to pick up inflammation in the arteries?
Yeah, you should do a panel that looks at all those finite responses like with inflammation, C-reactive protein,
sure,
interleukins, TNF alpha, oxidative stress molecules. You got a whole bunch of blood and urine tests for that. Myeloperoxidase is a great one for looking at oxidative stress, for example.
Okay. So you mentioned a couple of nutrients, potassium, magnesium. What other nutritional supplements help move the needle for patients with hypertension?
Well, the most important and most powerful is the nitric oxide and glycocalyx.
Okay.
They outweigh anything else you can do.
Okay.
Then you've got a bunch of other things that I've looked at clinically. You've got coenzyme Q10, kaolic garlic, alpha lipoic acid, magnesium chelates,
taurine,
Yeah, there's about probably 15 really good nutrients that have been clinically studied that help to lower blood pressure.
How do you decide which ones to recommend? How many do you recommend at a time?
Well, I measure what's missing. So
So
I get
you're
the
doing a micronutrient test. So
micronutrient test to see
start
what's
there.
missing,
Yeah.
and then you replace those. Now, if it's all normal, then you kind of go by what's got the best bang for the buck and replace those first based on the clinical studies.
So if you were going to put somebody, let's say the micronutrient test is normal, and you want to put them on, let's say 4 or 5 supplements, what would be the biggest bang for your buck?
All right, so I definitely would do Vascunox and arterial in
Okay.
combination. Then I'd probably add magnesium chelates,
Okay.
then coenzyme Q10, and taurine. Now, there's a really great product that I developed with Biotics. It's called CardioCert BP, and we
Okay.
did a clinical trial with it. It's a powder, and it's got a lot of taurine in it, along with magnesium. So you can get a lot of that just by doing the CardioCert BP. It's really good. It's 1 scoop a day in water, and we got pressure reductions of like 12/6 with that one.
And you got to go a fairly high dosage of taurine, right? What kind of dosage?
So we've got in that one we have 6 grams a day.
Okay.
Mm-hmm.
And is that typically about the amount you're going to recommend, more or
Yeah,
less?
that the peak effect of taurine on blood pressure is 6 grams.
Okay. Cool. You also list in your book certain supplements that, when taken with hypertensive medications, enhance the effectiveness of the medications.
So there's synergy, or at least additive effects, with a lot of the nutrients in the drugs. For example, I'll give you a couple. Our lipoic acid with an ACE inhibitor, very, very good together. Magnesium with a calcium channel blocker. So you can look at the nutrient, sometimes add that if your blood pressure is not controlled just with the medication, without having to do a second medication. But the key is to make sure whatever you're doing gets the pressure down normal and pretty quick.
So when it comes to medications, you mentioned that you no longer use most of the diuretics. Which medications do you typically find to be the most effective?
So after we do our genetic testing and our plasma and aldosterone, the top classes of drugs are ACE inhibitors, angiotensin receptor blockers, 1 or 2 of the calcium blockers like amlodipine or nifedipine. And then the best beta blockers are nebivolol, which is Bistolic, or Coreg, which is carvedilol. The only diuretic that I use is indapamide, and indapamide is the best. Hydrochlorothiazide, no, don't use that one anymore.
I still see a lot of patients on that.
Yeah, it's one of those things that's gotten ingrained in the medical pharmaceutical industry, and once it gets in the pill, they can't seem to get it out, and people keep prescribing it. But there's data that HCTZ absolutely does nothing to reduce your cardiovascular events. And here's the really bad thing about it. If you give HCTZ by itself, you run a risk of type 2 diabetes and kidney disease that gets worse and worse by the year. Not to mention homocysteine going up, potassium going down, and other things. But if you put hydrochlorothiazide with what we would call a good medication, like an ACE inhibitor or ARB, it counterbalances the good effect of the other drug.
Oh,
So you
wow.
get something that's sort of halfway there. Not good.
Another drug I see a lot of patients on is spironolactone.
Yes. Spironolactone, eplerenone, and Corindia are all serum aldosterone receptor antagonists, or SERAs. And they are all very effective in most people with blood pressure. But particularly when you do the genetic testing, there's a couple of genes that respond only to that class of drugs. CYB11B2, for example, is the gene that responds to aldosterone oversynthesis. And the only way you can do that, block it, is with spironolactone, Corindia, or Pleuronone.
Yeah, but I don't know any doctors other than one or two like yourself who are doing those genetic tests.
Yeah, we need to get people doing genetic testing because that's the only way you can personalize and do precision medicine in cardiovascular disease, particularly high blood pressure.
Right. It seems like that spironolactone is like the preferred drug for women for some reason.
Yeah, well, there's a good reason for that. Spironolactone causes gynecomastia.
Oh, okay.
Okay. So men don't like it, but women like it, right?
Great. I think those are the main things that I wanted to discuss. I think we covered a lot in a short period of time.
Yeah, you got those questions lined up and banged them out. I mean, you're a pretty smart guy back there.
I'm thinking maybe we should try that controversial topic I asked you about before we started. There's a new controversy in cardiovascular medicine that's hit the news. Apparently, Dr. Stanley Hazen, who's the guy who developed the theory about TMAO as being a risk factor for cardiovascular disease, has started a controversy, and people are now nervous about taking niacin because of this paper that he published.
Well, let me comment on the paper. I have read the paper ad nauseum. It's published in Nature.
Right.
Okay? Nature's a pretty good
Very
journal.
respected journal. Yeah.
Very good journal. It's not a real clinical journal. It's more of a research journal. So let's say that up front.
Right.
So they take studies that are considered pretty high science, and otherwise they don't get published. So having said that, I don't have any issues with Nature. I don't have any issues with the fact that the study is in Nature and the study says what it says. Now, then you get to what does the study really say, and how did people take it out of context to blow niacin off the map again very inappropriately. So without getting too detailed, I'll give you the big picture. The study was designed to look at some metabolites of niacin. And those metabolites were not considered very nice metabolites. They were thought to be sort of toxic metabolites of niacin, and you don't want them. But in order to get those metabolites, you had to have a certain genetic SNP. So how many people have that genetic SNP? Well, I don't know, but it can't be very common. And so if you don't have the SNP, you probably don't get those metabolites. So it's not a universal issue by any means. It's probably a very small part of the population. The second piece was it was high dose niacin. We're talking 1,500, 2,000 milligrams a day. Well, we don't do that anymore. I mean, I haven't prescribed that much in a decade. If I give niacin, it's like 250 twice a day. You're not going to get in trouble at that dose with metabolites because it's low dose niacin and you may not even have the SNP. So the study was taken totally out of context by a lot of people, not so much Dr. Hazen, but other people said, oh my God, it's going to cause you to die from coronary heart disease and you can't use niacin anymore. It's terrible. And they start quoting clinical studies that are bad studies. So they're taking a study out of context and then tying it to a previously bad study to prove the point, which makes it even worse.
Right.
And we've already gone through that controversy 7 or 8 years ago, and that was all taken out of context as well. So there's a lot of things niacin does that's good. I mean, all the clinical trials with niacin using correct doses showed improvements in HDL, triglycerides, LDL particle number, coronary heart disease risk, and MI risk. But you got to know what you're doing. And you got to know when to use it and what to combine it with. So my message after having said all that is niacin is alive and well. You don't need to stop niacin. You need to use low doses of niacin and know what you're doing. And the only people that might get into trouble, and it's probably not big, is if you gave high doses of niacin to those people with that genetic SNP, but not in the general population. Niacin is one of the few things that actually improves HDL dysfunction.
And
And
also
Lp(a).
lowers lipoprotein A.
Yeah, Lp(a). So, it's got a lot of good uses. So you don't want to throw it out just because of one little study that wasn't designed to even answer the question that people are all upset about now.
It's kind of funny how this simple vitamin, which you and I and a bunch of other, especially integrative doctors, have been using for years with all sorts of benefits, is getting attacked again. And I don't quite know why, but
I can't begin to understand why they keep picking on niacin. It's a nutrient. It's vitamin B3. It's
right,
fine. It's in our food, for goodness gracious.
right.
I just think we need to back off a little bit. And here's my message for your readers. Don't listen to the news media reporting on medicine because they never get it right. If you're going to say, I don't want to use niacin, I don't believe in niacin, get all upset about it, go read the study. Read the study, read the methods, and decide for yourself, oh, that's totally flawed. I'm not believing that, and move on.
Right. Thank you, Dr. Houston.
Okay.
How can our listeners and viewers find out about your books and more about you if they want to work with you?
So you can go to the Hypertension Institute website. We got all kinds of information there you can download for free. And you can also make appointments to see us as a cardiovascular consult. The books are all on Amazon, so they're easy to find. You just put in my name and it'll pull up all the books that we've
How
done.
many books do you have? It's like a lot.
I think I'm up to 10 now.
Okay.
Yeah.
Thank you so much, Dr. Houston.
Thank you, Ben. I appreciate being on your show.
Thank you for making it all the way through this episode of the Rational Wellness Podcast. For those of you who enjoy listening to the Rational Wellness Podcast, I would appreciate it if you could go to Apple Podcasts or Spotify and give us a 5-star ratings and review. If you would like to work with me personally to help you improve your health, I do accept a limited number of new patients per month for a functional medicine consultation. Some of the areas I specialize in include helping patients with specific health issues like gut problems, neurodegenerative conditions, autoimmune diseases, cardiometabolic conditions, or for an executive health screen and to help you promote longevity and take a deeper dive into some of those factors that can lead to chronic diseases along the way. Please call my Santa Monica Weitz Sports Chiropractic and Nutrition office at 310-395-3111, and we'll set you up for a new consultation for functional medicine. And I look forward to speaking to everybody next week.